biological parents home, then you should, but that takes an informed clinician to be able to make that argument. But you should be able to do that. I like your guys' questions.
Can I say, too, that a lot of parents that are court mandated to treatment, to PCIT in particular, come in and they're not really very happy about being there. They're a little hostile. It feels like somebody's telling them they're not very good parents. But since they're mandated to treatment, they have to be there. But we found in our research that by the end of treatment, parents are really happy to have been there. Their relationships look better with their children. They rate their children's behaviors as improved, even though they minimize their children's behavior problems when they come in. And they also claim to be really satisfied with the treatment process. So I feel as though the process of treatment really breaks down a lot of that kind of initial hostility and feeling like, you know, you're telling me there's something wrong with me.
They sometimes want this video that we take of them in therapy shown to their social worker. I've had them want to have their social workers come in to watch a session because they've made some accomplishment. They feel good about it.
Should we maybe hear from DCFS in terms of their role with this project as well? So Robert and Donna, if you want to come up and, sorry, we stole some of your thunder in the process. But.
So I'm Donna Fernandez. I'm the program manager of the DCFS Child Welfare Health Services section. And one of the responsibilities my section has is programmatically ensuring that there's services to pregnant parenting teens. So when we first began the partnership with First 5 LA and DMH on PCIT, there was a common interest across First 5, DCFS, DMH, in serving the parenting teens with children 2 to 5, who the parenting teens are under our care and supervision. So we did some work, some outreach to the assigned CSWs of these parenting teens, and communicated with them about PCIT and kind of promoted the opportunity to review what PCIT is and make a referral of their parenting team to PCIT. And then we also went out to the offices and made presentations. That was probably in 2013. At the beginning of 2014, there was a decision by the leadership of us and I think DMH and First 5 that we would broaden the population of children served in DCFS who could be referred to PCIT. So that was any child who's between the ages of 2 and 5. So in January, we continued our presentations to the offices. Robert came on board because he's actually representing kind of the broader population. We'll explain that in a minute. But so we've gone out to all our offices and presented PCIT. We've also actually jointly gone out to the kinship caregiver group. We've gone out to the child advocates. We presented to CLC, Alliance for Children's Rights.
Judges?
The judges.
And somewhere in there we apologize if you're sort of latter on the list.
And so now the goal in terms of the next steps is to continue to sort of drill down to help familiarize our line operation staff about PCIT. So we put out a communication and have some dates to go out to actual supervisor units in our offices to better explain PCIT and see if there's an opportunity to make referrals. And actually, in setting up the referral process, we didn't want to do anything really different than what already exists in DCFS. So we've implemented a process where the CSW fills out the client-centered referral form, and on the referral form can note, referral to PCIT. And then the beauty of that is that goes to the service linkage specialist in the offices, and then the service linkage specialist communicates with the DMH co-located staff. And it's really the DMH co-located staff that makes sort of the kind of first level determination if it's a good fit with PCIT. And let me say that the beauty of that is getting in the referral, even if it may not in the end be a referral for PCIT, the co-located DMH staff have an array of numerous evidence-based programs that they can redirect the child to, correct?
That's correct.
So, my name is Robert Wiltsey with the Bureau of Clinical Resources and Services, formerly known as Dr. Sophie's Bureau. I do have staff in all the offices, as Donna mentioned, the service linkage specialist staff. The way that this particular treatment option has been set up for clients is really good. Bill's done a great job partnering with DMH and Dr. Keys and so on to set up capacity. Most of you have been around a while, know that it's nothing more frustrating than trying to order or get a client into a program and you find there's a long waiting list or so on. That's not the case here. They've done a really good job this past year in building capacity. And as Donna mentioned, the staff work with the co-located mental health staff, which are in the offices in DCFS as a result of the KDA lawsuit, to make sure that we get kids linked to age-appropriate mental health services in a timely manner. The one cautionary point that I'd make with this, as well as we did with the bench officers a month and a half ago or so, because they all wanted to order it, was that you have to make sure that this is a proximity-based service. In other words, it has to make geographic sense for your client. Unfortunately, as we know, there's a lot of kids placed in foster care all over the county where the parent may not be in close proximity, at least especially when the case first opens. PCIT is not going to be appropriate for the birth parent if she's living in Bellflower and the kid's placed in Lancaster. That's really not doable. However, later on in the case, when they get back in proximity, then that's going to be an appropriate or realistic thing. It's not going to frustrate the parent for trying to take 4 different buses to get to the appointment. And as we mentioned earlier, we all know from reading the LA Times, it would be good to be able to boost the quality of parenting that our foster parents give, as well as kinship care providers and so on. So knowing that your parent can take this course later on with the child is something that I see as really being a win-win for all the people who are caring for our kids in LA County. The other thing that I would make note of is that there are several other evidence-based practices, incredible years, CPP, child parent psychotherapy, that can be good for the kids if the parent is not in physical proximity for PCIT. So just rest assured that as we encourage the bench officers, you can't tell them to do anything, so we encourage them to order age-appropriate mental health assessment and services for the clients rather than naming a specific evidence-based practice. That's really the job of the co-located mental health clinician in the offices who are familiar with the case. And then do you have a question? Yes.
I do. How much education is happening with like the ER workers in terms of putting in a PCIT type service in place before filing petitions? Because it sounds like this would be an appropriate, reasonable services issue prior to detention. Is that something that's been? It sounds like it's mostly
the ER workers have certainly been part of the presentations, been made aware of that. Whether their supervisors or ARAs are letting them make a referral that early on in the process, I don't know, quite honestly. That's something we can certainly look at.
So
yeah.
if the attorney asks the court to make the order, they can't say PCIT, they should say.
So for example, if for the case I gave earlier, if mom's living in Pomona and the kid's in a foster home in Santa Monica, it frustrates everybody, and that order's there on paper and they're trying to work around this craziness. So that's why if you do a kind of a blanket language of age-appropriate mental health services and assessment, then that gives the clinician in the office who's working with the parent, you guys, to know what's going to work, the best chance to fit.
We have to rely on the social worker that's carrying the case to make that evaluation, to send it out to the right program?
Along with the DMH co-located.
No, it's not the social worker makes a referral and can, note, PCIT question mark. Then it goes to the service linkage specialist in the office who works very closely with the co-located mental health staff. Now, the co-located mental health staff are really the experts and to really drill down and see if it's a good connection with PCIT. If it is, it moves forward. If there's another evidence-based program that is more appropriate, then that connection moves forward.
And that is working, quite honestly. We doubled the number of referrals we had from last year. So, DMH clinicians are more aware, and they don't want to refer clients to programs that have waiting lists either. So they know the capacity is now built, And so we're trying to make sure that once they get in there, and then the agencies build Medi-Cal, so it's sustaining program.
And I just want to add that when we presented to the hearing officers about a month and a half ago, we did discuss giving them kind of a language to use in a court order. So we hope that, you know, they move in that direction.
So why can't we just say, department to look, immediately look into PCIT or any other mental health? So we focus the department in that we want for them to look at that. So we get a little, you know, bit of help. Why can't we focus in and then say, or any other mental health?
Yeah, I think the idea of PCID question mark, like is, you know,
But we
age
wanna
appropriate or
get the order, yeah.
Yeah, or
Right.
PCIT, you know, sort of suggests. I think it's just, you know, I've already had a few calls in my office where somebody's trying to refer, doesn't understand the interventions, trying to refer a baby to the case, and you know, it's frustrating because you want some service, but at the same time, this is not an appropriate case. It's 2 to 7, so not everybody is you know, eligible by age or medical necessity. Hopefully, most people would be eligible by medical necessity. I know there's a burning question back there. So.
I just had two questions. One is, I have about like 300 parents. There isn't a single one of my cases that utilizes PCIT. So I'm very concerned that there's this program out there and 0 of my cases have PCIT. The other issue is I have parents regularly traveling up to an hour and a half every week to see their children. So I don't understand if they're traveling that every week to have a visit, why they couldn't also have PCIT, because many of my clients travel regularly on a weekly basis to visit at the foster placement. So I guess I don't see why that is a barrier to PCIT.
And that's, you know, those of you who've been around a few decades, can you, kind of the age-old question, can you count, or should a therapeutic intervention be part of visitation, and should they be separate? I mean, that you can go back and forth on that. So I think that that's a great question to pursue, and I think that as you work on these individual cases with a particular parent, the reliability and quality of the transportation, are they relying on a bus line to get them there on time versus driving? All those things kind of factor into whether, you know, it would be realistic for PCT to be.
I guess my question is, if the parent is willing to travel and it is not missing any visits, is the department then saying PCIT is not appropriate because the parent would have to travel? That's my concern.
So
Go ahead.
I can speak from experience as a clinician doing PCIT, and I've worked in my focus at the agency I worked at was specifically with children in DCFS who are somewhere in the reunification process or being adopted. And for the most part, the PCIT does expect buy-in and input and energies from the parents more than I think some other practices. And that's why it becomes harder when we have all these factors like less contact, more distance, maybe poor communication with the foster parent. All of those become barriers to this child and this parent having success in the program. So we want parents and children to feel successful in the program. So I would not ever put a blanket statement and say no child who's placed within a certain amount of radius can have PCIT, where they're, you know, I think there's always certain cases where it can work. So that's, again, where I wouldn't personally put a blanket statement over it, because I've had clients to where it worked. I've also worked with foster parents and then worked with the bio parents. And like Anthony was saying, it's a process and having a child who's already been through PCIT, be able to translate those skills into the parent sets both of them up for success in so many different ways, because the child knows this is a safe process, and now my parent is being, you know, integrated into this safe process, and I know it's safe because it's predictable. I know what happens every single time I misbehave. I know this time I'm not going to get hit. I know what they're going to say, how they're going to say it, how many chances I get. It becomes, again, safe, and safe means predictable, means success. So going back to your guys' question, like the 300, that is kind of concerning to hear.
Well, and I'm just saying, I'm not aware of any child receiving PCIT.
Well, let me just say,
That's a lot.
real quick that, you know, I don't have the numbers, but DCFS and DMH have shared the numbers of referrals for PCIT and cases being, and
I can
it's
tell you it's
increasing,
worthwhile,
it's increasing.
and I have no child that I'm aware of.
Well,
Yeah, so-
it's increasing, and certainly
What are the
the,
numbers?
Well, then
Let's
it's
just- what are
great
the numbers?
that you guys
So
are here.
I think we served maybe like 1,200 DCFS cases,
In
I
Los
think,
Angeles?
last year. So
This courthouse?
yeah, so, but I mean, I think those were the numbers that I recall seeing, but the thing is that there's still, remember I said 11,000 kids 0 to 5 in the DCFS stats, so that's like, 10%.
Can I ask
You
you a
know,
question?
what I wanted to say is that we've been increasing, each year. The first year when we started this, there were 13 agencies in the county delivering this service. Second year, we added 21 agencies. Third year, we added 18 agencies, and now this next year, we're adding more. So we're ramping up capacity to do more and more, and so we're hoping that by the time we're done in this 5-year project, that we've really developed capacity to serve many more of those 300 cases throughout the case. So, and that's why the purpose of these presentations is to make, folks
Right.
aware and to try and increase utilization. That's where we're hoping from
and
this
it's-
right,
presentation.
and as I said, DCFS, the goal is to continue to drill down to, within the offices to really help educate
So,
staff about PCIT.
We just want
And
to know-
continue to
You
do
don't have the
presentations.
numbers, but I'm just curious, since the judges have been making, since they've been trained, and they're making these orders with this language that you suggested to them, how many referrals
but we,
have there been made
brand
from those
new.
orders to PCIT?
yeah, so we met with the judges a month and a half ago, so it's still
I'm talking about
fairly.
parents, not for the
Not
foster.
kin gap, parents, we want to know how many
Parents.
kids. Parents.
That's what I would like to know.
Yeah, so I don't think we have
Yeah,
the
those
exact
numbers.
numbers at the moment at our fingertips.
So we're wrapping up, and this is a great opportunity for you guys to advocate for that for your parents, because the capacity's been built. It'd be kind of foolish to roll this out and not have capacity built first. So the capacity is there. Now we need you guys to help get a lot of referrals made so that the agencies
Yeah,
delivering
we
the
hope the
service can sustain
DCFS
it.
workers or the linkage people, whoever you're talking about, in the bureaucracy, actually makes those referrals and assesses the parent and the child for those referrals. I have a feeling that they don't do that very often.
And I can say, my concern too is these are a lot of children that aren't even getting this service, because from my cases, I don't know of even foster parents that are getting this. So it's not even just the parents. I mean,
And that's why we're spreading the word. I mean, the more people
And
know
a lot of
about
the
it.
agencies have been reporting to us early on that they've been having difficulty with referrals. So I think that's the whole purpose of these presentations, is try and help make you guys aware, CLC, dependency court judges, DCFS. We've been out to all 19 offices. So we're just trying to keep getting the word out. Sandy Banks did a story maybe 8 months ago in the LA Times about the use of PCIT with an adoptive family. So all of these hopefully is helping to get the awareness up so that we can get more utilization of the service.
And Mr. Brown, it
You
actually.
need to help get something like Sandy Banks to write an article about how it's used with parents successfully. Okay, because I think a lot of this stuff is being done for adoptive parents, for kin gap, for foster parents, and lots of times that's facilitating these kids probably bonding to these people and not going home.
I think far and away the DCFS utilization has been, by and large, with birth parents, that the number of kin gap and adopted homes is really small.
But we don't see it.
So really quick, I just want to let you guys know that this is in your packets, and these are all the agencies that do provide PCIT, and it's divided by service areas. So it's divided by location, it has their address and contact numbers.
Could you put more of those out? They were out.
Yeah, okay, I'll pass these around right now.
Quick question, there's so many kids that are placed out of LA County that are in our system. Is this program available to them?
Well, it's limited to the sites that we have. I mean, I did a presentation some time back out at Citrus College, and they were talking about a lot of kids being placed in San Bernardino and Riverside,
Correct.
from that sort of eastern portion of the county, and that question came up. And so some of the agencies have catchment areas all the way to the border, but right now, it's a center-based intervention, so the service is delivered at the center. So all these sites that we're passing around is where the service exists. So it's not, some of the agencies over time with a lot of practice have developed in-home practice with